Welcome to the Motivational Midwife. I'm Lynn Jones, and today we're starting our Back to Basics series with vital observations and maternal temperature. So back to basics, vital observations, and we'll start with maternal temperature. So this can be defined as a measure of heat inside the body, but you've also got to think about it's the body's ability to produce and lose heat as well. And it's important because we have quite a narrow band where we need to keep the body functioning within to maintain homeostasis. And homeostasis is important for our bodies and our cell function to be optimal. And temperature is one of those key vital signs when you're doing a holistic approach to someone, you're undertaking an assessment. You really want to do that whole holistic approach. So temperature, pulse, respiration rate, blood pressure and oxygen saturations are your 5 key vital signs that will give you crucial information to make decisions on the condition of the person you are looking after. And let's just take a little step back and think about what's going on with temperature control. So the skin is our major organ that really helps us maintain our temperature. But the hypothalamus is what controls our basal metabolism. And as we've said, we need that to be maintained for our normal cell function. So when the body gets hot or cold, the hypothalamus kicks in and triggers various things to happen to help us either lose heat or gain heat. So if we look at getting cold first, the hypothalamus will trigger muscles to start shivering to try and produce some heat. It will trigger those muscles to contract and body hair to be pulled upright, so it traps a layer of air around our body that can be warmed up and keep the heat in. It also triggers the autonomic nervous system to cause vasoconstriction. So blood flow to the skin is reduced, it's slowed, so that we don't lose heat through those passive measures such as convection, conduction, radiation and evaporation. And someone who is cold often looks quite pale, their skin feels cold to touch. Conversely, if we're looking at someone who is got a temperature or is very warm, the hypothalamus triggers the sweat glands to start producing more sweat, so we lose heat through those passive measures, and the autonomic nervous system will trigger vasodilation, so the blood vessels get wider, blood is sent to the surface, closer to the surface, so we can lose heat through those passive measures. And things that can affect temperature. So some things will affect temperature. They can go up or down, such as the ones that I've got asterisked here. So environment. If you think if you're standing with very few clothes on in a snowy area, you're obviously going to get cold. Whereas if you are on a very warm beach in the Caribbean, then your temperature is likely to rise. Eating and drinking can have an effect on your temperature. So that's important to just find that out before you undertake the temperature, because you may then modify where you take your temperature, the site where you take your temperature. If she's just had a hot cup of tea before you go to take her temperature, the chances are that actually that's going to read as high. Sleep and calorie restriction tend to reduce temperature, and most women are aware of the fluctuations in their temperature that go along with their menstrual cycle. So looking at some terminology that's often linked with temperature. So what you will hear most commonly in practice is pyrexia or pyrexial. But this is essentially hyperthermia. So anything that is hyper is high and anything that's hypo is low. I always think of po, low. So hyperthermia or pyrexia is really when the core temperature is above 37.7. And severe and critical hypothermia or hypothermia really can cause ultimately death. So we really need to be quite observant of temperature. And hypothermia crucially is below 35 degrees. However, when you're completing your maternity early warning obstetric, your Myles early obstetric warning signs, isn't it? Maternity early obstetric warning signs chart. Below 36 will often trigger for you to act and have a look a bit closer at what's going on. And certainly on the systems that the computer systems that we use where I currently work, below 36 will trigger you to look at a sepsis scoring tool to see if there are other symptoms that this could be sepsis, because with sepsis and particularly septic shock, the temperature could be low as well as high. It's not really a very reliable indicator of sepsis temperature. Okay, so sites for taking temperature. So we have orally, so in the mouth, axilla, under the arm, and tympanic is in the ear. And because that tympanic membrane does share the same blood supply as the hypothalamus, it really should reflect what the core temperature is. You won't see rectal temperatures being used routinely anywhere particularly, but certainly not in maternity. When I trained many years ago, it was the method of choice for taking babies' temperatures. You used to have a mercury thermometer and you would do a rectal temperature at birth. It's not done anymore. I don't believe it's done on the general side either for any patients. So when we're looking at how we take a temperature, obviously you're undertaking a procedure, you need to gain consent in line with your NMC, both the code and your standards for proficiency. So if we're doing an oral temperature, you want to put the thermometer, and there'll be different types of thermometers, but most hospitals have digital thermometers with a disposable probe cover that goes over the probe. And you would put that probe in the sublingual pocket, so under the tongue, and get the woman to close her mouth. If it's axilla, then it needs to go really in the center of the axilla, and then get them to bring their arm down and just keep their hand across their chest to keep the thermometer in place. And if it's tympanic, then it needs to be snugly in the ear canal, and that may necessitate you pulling the pinner slightly to be able to get the probe in snugly. And then, depending on the type of thermometer you're using, you wait the prescribed time and take the reading. Inform the woman of her results, and crucially document it in the appropriate place depending on where you are. If you find that your result is outside of the normal range you're expecting, then really you need to escalate that. As a student, you would escalate that to your supervisor, but if you were a midwife, obviously you're going to escalate that to the doctor. And so what happens in pregnancy? Well, heat generation in pregnancy increases by about a third. So that is because we've got increased metabolism. Our basal metabolic rate increases because this woman's body is now producing a lot of energy. She's growing a baby. She needs more energy to actually grow that baby. And it's our progesterone that increases that basal metabolic rate. So fetal temperature is up to a degree above mother's. So you can see that this is quite important. If the mother has a raised temperature, then that fetus is also going to have raised temperature. And if we are looking at the very early stages of pregnancy, this really can be quite problematic. But certainly from a labour perspective, if you're thinking of women in particular using the pool, the birth pool, then most units will encourage you to monitor women's temperatures hourly in a birth pool, because obviously if they have a significant raise in temperature, the fetus's temperature will also raise, and that could also present as a fetal tachycardia, which would then cause you to potentially interfere unnecessarily. So it is important that we monitor in labour if they're in the pool very closely. So when might we take it? As I've said, we would take it in labour, but certainly any admissions to hospital, you want that full holistic assessment. If you were, for my own personal practice, when I was a community midwife, I would also do it on the first visit that I would see someone at home, to give me a baseline, of where they're at the point I take over their care. And again, I would, my own personal practice would be, I would do a full set before I discharged somebody from my care, because I am, whether that's in hospital, going home, or at home, discharged to the health visitor and the GP, because I want to ensure myself and the woman that there are no concerns, that everything is absolutely as I am expecting it to be before I say she is fit for discharge from my care, and there's nobody I need to refer to or escalate anything to. If we've got any concerns about her condition, does she look unwell? You know, when you perhaps look at her blood loss, is it a little bit higher than you'd be expecting? You might want to undertake a full set of observations to give you a bigger picture. And certainly in labour, in line with national guidance, you would be taking it, depending on if there are any other issues going on. But currently, as national guidance stands, it's 4 hourly for maternal temperature in labour. But as I've said before, if she's in the pool, then you might increase that to hourly. And there you have it, maternal temperature. I hope you found that useful. If you haven't subscribed to the channel already, please do. And I look forward to seeing you next time.